Hi, everybody. My name is Stephanie Markle, and I am a acute care trauma surgeon at Ascension Borges, which is affiliated with Western Michigan University's medical school. I am initially giving this lecture to the surgery residents who I teach, but I have also invited some community faculty members who have maybe no experience or very limited experience with managing ventilators because there's been great interest in this current situation that we are experiencing. So this lecture is Vent 101, some very basic vent strategies, basically how to choose a mode, what exactly that mode means, and a lot of basic understanding of what the ventilator is doing. This is not going to focus on respiratory physiology, how to treat specific disease processes. This is strictly understanding the machine itself in some very basic ways so that if community members are called upon to help in the intensive care unit or manage patients on ventilators, this will at least be an introduction. So we will start. Again, I have no disclosures to make on any of this. The objectives of this lecture is going to be very brief. We're going to review terminology as it relates to ventilators. We will describe different modes of ventilation, possibly start to understand why you would choose one type over another. Talk a little bit about spontaneous breathing trials, criteria for liberation, and some caveats regarding COVID-19 patients. So I like to consider the vent rules. The vent rules are the vent is not therapeutic. It does not cure the disease. What the vent does is it supports underlying function. So just make sure that you understand that concept because the vent does not fix the problem. So also respiratory therapists, they are the boss. So when you make changes, you want to do anything to the ventilator, make sure they are aware. Obviously, there's more ventilators than there are respiratory therapists, so they can't be present at every ventilator at every minute. But if you are going to make some changes or you have questions, please include them. They are the ones ultimately responsible for the machine. Compliance in terms of lung compliance is something that we'll talk about a little bit later, but it is something important to monitor daily because that is something that changes in each patient on a day-to-day basis based on their disease process. Do not cause more harm with the vent. The vent is not a benign machine. The vent can cause problems. So we want to limit the problems that are caused by something that we are hoping will support and prolong life long enough to correct the underlying condition. Also, liberate early. Liberate is basically what the intensive care talks about when they talk about extubation. So we're all on the same page on terminology. A quick little scenario just so you can have the brain sort of thinking about when people need to be on ventilators. So this is a 65-year-old female with a history of chronic kidney disease, recently had a right hemicolectomy for a malignancy. On post-op day 5, the patient develops a leak, returns urgently to the OR for control of her sepsis. While in the OR, develops hypoxemia. PaO2 is down to 85 on 100% FiO2, putting this patient's PF ratio at 85. The anesthesiologist did the correct thing by keeping the patient intubated. Now the patient is being transferred to the intensive care unit on mechanical ventilation. So the concepts here are really what caused it, because that's what we have to fix. Because again, the ventilator doesn't fix the disease. So here's a big list. It can be a lot of things. It can be, number one, it can actually be a true lung problem. It can be a systemic problem that is manifesting by poor respiratory mechanics, or it could be a cardiac issue. Either way, that's what you have to work on treating while the patient is intubated. Concepts of respiratory failure or the need for mechanical ventilation can be one of two problems. Either it can be an oxygenation problem or a ventilation problem. Oxygenation is basically where there is a challenge of getting oxygen into the blood or oxygen into the lungs. So there's that caveat. Well, ventilation is either you have increased dead space and you're not able to participate in gas exchange, or you're just not able to exhale. There's a overproduction of CO2 based on a metabolic cause. Those are things that also have to be fixed while the ventilator can assist you with those things. Okay. Also, yes, you can have both an oxygenation and a ventilation problem at the same time, but there is usually one that is more pressing at the moment. We will all come back to this, assuming that we have time at the end. Okay, so this is just so everyone is on the same language when approaching the ventilator. So I've given all of the abbreviations along with the full names and the definition. So tidal volume is the volume of gas inhaled or exhaled during each breath. It is always done in milliliters. The respiratory rate is the number of preset mechanical breaths the patient receives per minute. So this is something that you set on the ventilator. These are all things that you can actually change on the ventilator. Minute volume is simply an average volume as it's entering and leaving the lungs per minute, and this is something that is a calculated number between the volume and the rate. So the volume and the rate are manipulatable to change your minute volume. Fraction of inspired oxygen, always referred to as the FiO2, is the percentage of oxygen delivered. We can deliver anywhere between 21 to 100% oxygen. PEEP, which is talked a lot about, especially in this time with COVID-19, as these patients generally require PEEP and high PEEP. This is the positive pressure that is held in the lungs during exhalation. This is what keeps the alveoli open. This is what allows for gas exchange. So some other concepts we will kind of briefly talk about. These are also things that can be controlled by the ventilator, and it's the ratio of the time spent in inspiration to expiration. The vent is only active during inspiration. The only thing that we can control on a ventilator is during the inspiratory time of the breath. So I can determine how much oxygen is being flowed in. I can determine the milliliters of volume that is delivered, the pressure at which that volume is delivered. But what I can't, basically the vent turns off and the patient passively exhales. The vent does not suck air out of the lungs. That is the passive process. So the vent is really only on during inspiration. I can control the time that I allow for expiration, but that is really the only manipulation of exhalation that we can participate in on the vent. So true to remember that the ventilators, as we now know them, they're all positive pressure ventilators. This is not the days of the iron lung. The iron lung was a negative pressure ventilator system that did not require the patient to be intubated, and that is a very different type of mechanical assistance. So the only thing that we are talking about today is positive pressure ventilation. All right, the two others that are going to be important to know. It's called the peak inspiratory pressure, and this is pressure that is recorded at the end of inspiration. This is dependent either on volume or pressure, and the airway resistance. This is a number that is provided to you by the ventilator. Next, an almost more important one is the plateau pressure. Now, this is the pressure in the alveoli at the end of inspiration during a forced inspiratory hold on an assisted breath. So this is a physical maneuver that has to be performed on the ventilator to achieve this number. So we'll kind of come back to why the plateau pressure is so important to know on a ventilator, because it is something that can cause barotrauma. And again, going back to our basics, we don't want to cause more harm. So the modes on the ventilator. Number one, I will tell you that you can oxygenate and you can ventilate a patient on any mode of choice on a ventilator. Although it's good to sort of understand all of the different types of modes, what you set and what you monitor, so that if the patient is basically telling you that this mode is not working for them, you know how to adjust things to achieve your goal. So your goal Is it either going to be, I need to oxygenate this patient better, or your goal is I need to ventilate this patient better, or your goal is simply I need to support this patient because they don't have a mental capacity to protect their own airway, okay? So understanding the modes of ventilation is kind of twofold. One is how the machine interacts with the patient, and the other is how the patient interacts with the machine. All of these things go by basically four things. They're either by time, they're by flow, and then volume and pressure, okay? So this is, again, the screen might look different depending on the style of ventilator that you are using by the manufacturer. Some of these things are also trademarked in terms of their names. So I'm gonna use very basic terminology so that no matter what vent that you are working with, you will be able to understand what is happening. So this is what the screen will look like in the room of a patient on a ventilator. The top line is what the patient is doing. This changes every single breath. This tells you what the patient is actually doing. So this big letter in the corner, the C, this is telling me that this breath is controlled. And we're gonna go through the types of breaths, which are A, C, or S, assisted, controlled, or supported, okay? And we'll go into definitions of that. I just wanna sort of explain to you what you see on your screen. This is your peak pressure, okay? Now, your peak pressure changes obviously with every breath. The other thing is up here where it says PEEP, this is the actual PEEP that the patient is getting every single breath. It changes. Yes, it's set at 5, but it changes. We have the IE ratio, we have the frequency or the rate, the tidal volume that the patient took was 522 cc's to result in a minute ventilation of 13.2 liters per minute. Okay. Moving on, at the very bottom of the screen, this is actually what the physician has set in terms of settings on the ventilator. So I could tell you this patient has a set rate of 24. Their tidal volume is set to deliver 500 cc's per breath. It is got a max volume delivery of 75 liters a minute. But again, that's not necessarily something that you have to worry about. Same with this little symbol down here of the style of breath that is performed. Respiratory therapy can really help you and educate a little bit more on the specifics if you ever need to know. The other thing that we have here is the fractional excretion or fractional amount of oxygen, sorry. This is 45% and a PEEP of 5, okay. The other thing that we have on this is currently the screen is in a frozen mode after somebody did an inspiratory hold to give you the compliance as well as your plateau pressure. So as you can see here, it says PPL, that is your plateau pressure, and your compliance of 40, okay? So just all things to consider. Again, another view of the screen of somebody changing the IDE time, just so everyone kind of understands what we're working with. Okay, back to the types of breaths. I mentioned earlier you can have 3 kinds, either A, C, or S. So a controlled breath is something completely done by the machine. Whatever rate you set, let's say that you set a volume of 500 cc's. That means that every 6 seconds, if you have a 10 breath a minute, every 6 seconds, the patient gets 500 cc's. Every 6 seconds. If your patient chooses to take a breath at 3, it's very possible that the vent will not allow it if you are in that type of a setting, okay? This is a completely controlled setting. But if you allow the patient to trigger the vent, and let's say they want to take a breath at 3 seconds, the machine will deliver 500 cc's at that 3rd second. So whether or not the patient actually wanted 500 cc's or not, they will get that forced breath. Now imagine you have a straw in your throat and somebody forces air into that at a set pace and a set cadence. Now, In natural life, we all sort of breathe a little differently. Each breath is a little different. So on the ventilator, each breath is exactly the same, especially in this type of a controlled breath mode. In an assisted mode, this is when the patient actually like triggers the vent and gets that full vent, okay? So on that first picture where it had the C in the corner, that means the patient did not initiate the breath, the machine did the whole breath. If that letter changed to the letter A, that means that that patient initiated that breath with some type of trigger. Either usually it's a negative force on the endotracheal tube that allows a change in pressure. Therefore, the vent assesses that and gives the whole breath, okay? A supported breath is basically like they are breathing at their own rate, at whatever volume that they can take, and they are just added like a little bit of support. This is basically, think of doing pull-ups at the gym, right? If you just sort of hang there and you do nothing, that's the ventilator doing all of the work. You're not actually gonna like do anything. The next one is you start to sort of do a little bit of work, but the ventilator takes over and actually does the rest. Or in supported breath, you're actually like doing all of the work. And maybe you're just getting that extra little push very at the end. But truly, you're the one doing the work, okay? So compliance is something that is talked about with respiratory physiology. Compliance is the change in volume over change in pressure, right? We talk about compliance in all types of physiology, cardiac and respiratory. So this is the same kind of concept. It's always a change in volume over a change in pressure. So this determines the ability of your lung to stretch and basically like exhale. So how big the balloon gets and how much the balloon will kind of restrict back down. So when you have a low compliance, that means the lungs are stiff. You have a hard time getting air into the lungs. This is usually creates an oxygenation problem, okay? If you have an increase in lung compliance, it's an obstructive concept of disease. What it is your lungs are so stretched and flimsy that they don't have the elastic recoil to get the air out of the lungs. So these have very different management concepts when it comes to the ventilator, okay? This is why compliance is so important, and it changes. So this is how I like to view vents. I like to have everything sort of in sections so that it's easy to understand. So the vent basically has 3 different modes. And again, the top row is how the vent interacts with the patient. So you can either have it be set to a volume control, a pressure control, or basically nothing, okay, which is spontaneous. The next row is how that patient interacts with the ventilator on that type of mode. And as you can see, you can have an assist control, which is AC, or an SIMV, which is a synchronized intermittent mechanical ventilation. You can have either interaction on either a volume control setting or a pressure control setting. Under pressure control, there's 2 others, which we are barely going to talk about. They are a little bit more advanced. APRV and bilevel, which is a trademark name. So we will kind of briefly, but those are usually the modes, sadly, that are used mostly with COVID patients. Moving on. Okay. So back to volume control. When you have a volume control, what your goal is you set the volume to be delivered, usually 4 to 6 cc's per kilogram, and this is based on ideal or predicted body weight. So not the actual weight of the patient. So lung protective strategies, we sort of lean closer to a lower volume, like a 4 cc per kilogram, but you don't ever want to go more than 6 cc's because again, you risk trauma to the lung. Okay. When you set the volume, that means that you will monitor the pressure generated to deliver that breath. So this is where the plateau pressures and the inspiratory pressures come in hand. So if I set a volume of 500 cc's on a patient, I need to see what kind of pressure is generated in the airway when the patient gets that kind of breath. Now, this is basically where the compliance comes into play, right? So if it's a very stiff lung and I'm forcing in air, I might generate a higher pressure. And I need to be careful because I need to keep my plateau pressures less than 30 to avoid harm, and my peak inspiratory pressures less than 40 to prevent, again, harm and trauma to the lung, which is just going to worsen your disease process. I mean, it also can cause a pneumothorax, and you'll need to put chest tubes in and other things. So those are the ideas to know about, is those what you have to monitor. So if those are too high, you might have to adjust your settings, you might have to increase your sedation. Sort of depends on the situation. Here's a little graph, basically kind of talking about, those are balloons, by the way, talking about the pressures. So when you have a balloon that's poorly inflated, then you inhale and you get to your maximum inspiratory pressure. And then you want to like sort of keep that open, because that is where your oxygen exchange is happening. Now, the difference between your peak inspiratory pressure and your plateau is actually called your resistance. So that is also a number that can change. So also things to consider when troubleshooting these patients. If you have both an increase in your peak inspiratory and your plateaus, that's a problem with the actual like lung itself to some degree. If you have an unchanged plateau pressure, meaning the alveolar pressure is the same, but you have an increase in your inspiratory pressure, you have a problem external to the lungs. Probably a kinked airway, you could have a mucus plug, you could have a bronchospasm, but it is not at the alveolar level, like if both were increased. Okay, so it does sort of help you to determine what is happening. Moving on a little bit, because we just got to get through all of the modes on this basic lecture. So pressure control. So in pressure control, here you basically set the pressure that is going to provide your volume. So I, let's say, set my pressure at 20 centimeters of water. And then what I want to see is what type of volume is delivered based on that pressure that I set. This is a much more, in my opinion, physiologic mode. It is more comfortable for the patient. If you have a patient struggling on a volume control, it's because I don't take the same volume of breath every single time I breathe. It is uncomfortable to force more air into a patient than they wanted. With pressure control, which is sort of how our lungs work anyway, is based on negative pressure, but that is something that is seemingly more comfortable for the patient. But you do have to sort of monitor to make sure they are having adequate volumes achieved based on your pressure, because you still need to have the adequate minute ventilation and you still need to have adequate gas exchange. But that's the concept behind pressure control. Again, the variable settings on either pressure or volume control, you can always adjust the oxygen, you can always adjust the PEEP, and you can always adjust the rate. Okay? That is regardless of how you set the breath delivery, okay? A little bit more about assist control. I know we sort of kind of talked about it earlier, where you either have that assisted breath or that controlled breath. So that is basically what assist control is. Either the machine does everything, that's great in your paralyzed patient, for instance, and you control everything about the breath. And the patient can still initiate that breath, but they get the same breath every single time. So even if they just barely initiate that breath, they'll get whatever your breath is set at. 500 cc's delivered at, a 70% velocity rate, whatever that is what they get every single time, okay? The difference is with SIMV. SIMV allows a secondary sort of interaction with the vent, where if the patient triggers the vent only gives support and allows that patient to get whatever breath that they want. So let's say you have that rate set at 10. So every 6 seconds, the patient gets a 500 cc breath. Okay. I now want to breathe at 3 seconds. But that 3-second breath, I get 300 cc's because all I've set was the pressure support that is given to me as the patient when I initiate that breath. So if I say, let's say 5 of pressure support, that is enough to overcome the resistance of the endotracheal tube and should be adequate enough to basically be breathing on your own. And then if the patient gets a bigger breath than 250 or 300 cc's, that is what the patient will get. So they can breathe on top of, or therefore at a faster rate than you have set. Okay, so that's SIMV. It's a synchronized mode, but the spontaneous breaths are the patient's own, not the machine's. So that's the big difference. Okay. APRV, again, I'm not going to go into very much on this lecture. I will do another lecture on APRV itself. This is called airway pressure release ventilation. Sometimes it is trademarked by some ventilator companies to be called bi-level, which is a little bit different on some ventilators. What it kind of does is it inverses your I/E ratio. It allows a very short expiratory phase. So long inhale, like, and then exhale quick, inhale again. And on your exhale, the key is not to exhale all the way and not to allow that positive pressure that is left in the lungs to completely leave. So it continually allows for oxygenation. What it will do is it will cause a permissive hypercapnia or a poor ventilation. So you will develop a slight respiratory acidosis sometimes in this mode, which is okay if oxygenation is your primary goal. And again, here what you're basically setting is your low pressure and your high pressure, or PEEP low and PEEP high. So that's basically, and it's sometimes reported as your delta P, or the change between your low and your high. All right, so again, different kind of mode, a little bit harder to sort of grasp and understand. So I'll do a whole separate lecture on APRV. Spontaneous is basically just that. The patient is given pressure support during the breath or continuous positive pressure, just like a CPAP. We use this mode mostly when you're trying to liberate from the ventilator, or if someone actually has been trached already and they're on like a trach trial, basically to see how well they can do without any support at all. So this is the spontaneous mode. So things to consider when you are troubleshooting. If you have an oxygenation problem and the patient is hypoxic, obviously do all of the very basic things. Check a chest x-ray, make sure your tube is in good position, make sure the patient didn't develop a pneumo. You could use lung ultrasound for some quick bedside assessment. But if you really want to alter your oxygen levels, really all you can do is change your PEEP, change your FiO2, or going all the way back to oxygen delivery concepts, you can add more boxcars. So you can add more hemoglobin, since that is where oxygen is bound. You might have to change your cardiac output. Maybe that's the actual problem with oxygenation. It's a pump failure. Okay, so that's oxygen. So PEEP and FiO2 will change your oxygenation. If you have a ventilation problem, I mean, it's still kind of also the concept of like, is it a cardiac problem or something other than the lung itself? But if you are trying to blow off more CO2, then you must change your minute volume, your tidal volume or respiration rate. Those are the two that really change your ventilation. Are you having a lot of auto PEEP where you have breath stacking and the patient can't exhale? Maybe you just need to prolong your expiratory phase. So there are sort of a lot of things that can happen with the ventilator to sort of help you decide what is the best course. Sometimes just trying a few things while at the bedside of the patient and see what happens. Okay, kind of running out of time, so we're going to quickly go over spontaneous breathing trials, which should be performed every day in conjunction with the sedation holiday. Things that cause you to abort, obviously a DSAT, change in your hemodynamics, and respiration rate. So those are things that usually stop your spontaneous breathing trial. And obviously only do these if the patient is a candidate for extubation. If they are paralyzed, for instance, they're not going to have a spontaneous breathing trial. If they are prone, probably not going to have a spontaneous breathing trial. If they are on 3 pressors, not going to have a spontaneous breathing trial. But as the patient is recovering from their insult, uh, you want to see if they're ready. And the only way to see if you're ready is to test it every day. So in my opinion, here are my thought process when it comes to extubation or liberation from your vent. Number one, did you correct the cause for why the patient was intubated? Huge. If you don't answer yes to that, then just stop there. If the patient is awake and following commands, again, understand if they were intubated for a neurologic reason and now they are aphasic, maybe they can't understand your commands, that doesn't necessarily mean they can't be extubated. So there's a little gray area on the awake and following commands. I do like patients to be able to lift their head up. I like there to be adequate gas exchange on a spontaneous breathing trial. I always want to know my airway assessment. If I am not the physical person who performed the intubation, I want to go back and read the intubation note. Was it a difficult airway? Did they have a bad view? What did they use to intubate this patient? Was it a glide scope? Was it a DL? Was it a fiber optic? What was it? Okay, important to know, because if this patient is going to fail and need reintubation, I don't want to be ill-prepared for a difficult airway when I could have had everything sort of aligned ahead of time. Or am I going to extubate somebody over a bougie cath? Or whatever I'm going to do, I need to know, because I need to know that airway assessment before I take the tube out. Okay. Also, the frequency of suctioning and secretion burden. If you are suctioning a patient every 10 minutes with gobs of secretions and a horrible pneumonia, and they can't cough, don't extubate that patient. They will fail and you will reintubate them, and they just were not ready yet. Okay. Next are the numbers, the NIF, the FVC, and the RSBI, because sometimes you need a little bit of actual documentation of a patient's physiological ability to withstand extubation. The only one proven with data is RSBI, which is your rapid shallow breathing index. It is something that can either be provided to you by the vent. It can be calculated based on your volume and respiration rate. What you want is a RSBI less than 100, less than 110. Again, this is a little bit of personal judgment. Take the whole patient into consideration. There are people with an RSBI of 60 that get reintubated, and there are people with an RSBI of 120 that do fine. But overwhelmingly, you want it less than 100. FVC is a forced vital capacity. This is just basically telling you how much this patient can have a lung capacity. Usually 10 to 15 cc's per kilogram is what I aim for. You go up to the patient, they're still on the vent, you tell them to take a big deep breath in and exhale as much as they can, and you look at the number. It's pretty easy. The NIF is a negative inspiratory force. Some of the vents, this is a little bit harder to calculate or achieve, but basically you want to know, can they cough, and what kind of negative pressure the patient can actually do on their own. Okay, so negative 30 is sort of like where I like to see it. We're gonna be ending this soon because I'm almost at my time limit, and we're gonna continue with a secondary lecture. So please look back. But some COVID-19 caveats. Number one, we have seen rapid deterioration in these patients. So these patients are on just some nasal cannula oxygen and rapidly deteriorate, usually with increased shortness of breath, work of breathing, and hypoxia. You do not want to use non-invasive options. You do not want to use BiPAP, CPAP, high flow. You basically will go from 6 liters of nasal cannula to intubation. And that is because you do not want to aerosolize the virus and expose more people to viral loads. ARDS is usually the type of physiologic picture that these patients have. So that is the strategy for oxygenation. We're using either ARDS net or basically a high PEEP, high FiO2, recruitment, proning, paralytics, those types of maneuvers for oxygenation in these patients. Also, there is some mixed data on this right now, but a lot of people are saying to delay trachs. Number one, you don't want to open the airway, open the circuit, expose your healthcare team by performing an airway procedure, okay? Also, if your patient isn't getting better in 14 days from COVID-19, there is a poor chance of survival, so I might not trach some of these patients. Um, because again, the trach is going to expose you and the healthcare team to an increased exposure risk. So delaying this if possible, because also you have to have certain types of vent settings to perform a tracheostomy. I don't do them on prone patients with high PEEP requirements. So you have to already be getting better and be showing me that you're getting better before I would consider traching this patient. And again, limit the manipulation of the circuit or exposure and opening up the circuit to the greater world because it is aerosolizing virus. Okay. So again, some quick take-home notes. The vent does three things. It provides your work of breathing, it provides pressure to reduce your shunts, and it provides oxygen in higher levels than you can provide via nasal cannula. Everything that you do with the vent, please coordinate it with your respiratory therapist. If you have a goal, if you know what you want to accomplish, but you just don't know how to accomplish that, talk to your respiratory therapist. They will help you, okay? Again, I just want to leave this for you. Save this. It will help you immensely in understanding the ventilator. All right. Basically with that, I am going to end this lecture and I will see you guys back for a lecture on APRV, bilevel, and management of ARDS. So thanks for watching. Hopefully this was helpful for some basic terminology.